So, without further ado, I would like to introduce today's topic and presenter, Dr. Ashley Weiner. Thank you so much for joining us. Dr. Weiner will be presenting Radiation Oncology, Management of Lung Cancer in North Carolina, an update on small cell lung cancer. Her full biography is available on the handouts that are available for this course, but what I would like to do is introduce Dr. Weiner through 5 professional highlights. Dr. Ashley Weiner, MD, PhD, is a radiation oncologist at the UNC Hospital in Chapel Hill. She received her PhD degree in biomedical engineering from Vanderbilt University and her medical doctor degree from Vanderbilt University School of Medicine. She completed residency training in radiation oncology at Washington University in St. Louis. Her clinical focuses are thoracic malignancies, primarily non-small cell and small cell lung cancer, and gynecologic malignancies, primarily endometrial and cervical cancer. And her number one professional highlight is that at UNC, she is the clinic medical director, the director of residency program in radiation oncology, and the course director of the medical student clerkship. So thank you so much for joining us. As I mentioned earlier, we will be using polling software throughout the presentation. This is what the polling software will look like when we get to it. And this is our first sample question. If everyone wants to go ahead and log into pollev.com/UNCLCN, you can start submitting your answers. While you're doing that, I'm going to leave up this disclosure slide briefly. Dr. Weiner has no relevant financial relationships with ineligible companies as defined by the ACCME. So now we will get to our first polling question. I'll give everybody a chance to respond. Go ahead and submit what one word comes to mind when you hear the phrase radiotherapy for small cell lung cancer. And we do have some answers coming in. Oh, Dr. Weiner, how are they doing? Are they hitting the mark?
Yeah, there's some really, really great responses so far, thinking about pain, side effects, fatigue, targeting the cancer. So these are all really, really great points that I think we'll be able to touch on. Someone said, ow.
Yeah, I like that one.
So very great, creative, and really insightful comments. So yeah, I'd love to kind of dive into these and talk a little bit more. So thank you so much, Andrew, for the wonderful introduction. I'll see. Living life. So we're getting some positive ones as well. So this is really lovely. So I will then go to my next slide, see a few more. And so again, thank you. I'm going to be speaking of some updates in radiation for small cell lung cancer. Again, thank you, Andrew, for the introduction. My objectives for this talk is I want you to be able to differentiate between extensive stage and limited stage small cell lung cancer. I want you to be able to describe the role for, logistics of, and toxicity of thoracic radiotherapy, so radiation to the lung in small cell lung cancer, and as well as talk about the indications for and the types of cranial radiation, so brain radiation for small cell lung cancer, because these are some of the big disease sites that we would consider for radiation. So for lung cancer, there are 2 main types. Non-small cell lung cancer, which actually comprises 80 to 85% of lung cancers. And those include a variety of histologies such as adenocarcinoma and squamous cell carcinoma. Small cell lung cancer is only 10 to 15% of all lung cancers. And it is known to grow and spread much faster than non-small cell lung cancer typically does. On pathologic specimens, small cell lung cancer is noted as small, round blue cells. They have a high Ki-67, which means they like to grow and divide. And they are often positive for the markers of chromogranin, synaptophysin, and TTF1. And that's how the diagnosis is made in our patients with small cell lung cancer. More than 95% of cases of small cell lung cancer are related to smoking. I've got my first poll here for you. And so what is the potential initial symptom of small cell lung cancer? The choices here we have are weight loss, cough, confusion, and all of the above. So it looks like the vast majority here are both in the poll everywhere in the text commenting on D for all of the above. So I'll go ahead and continue to my next slide. And truly, all of these can be symptoms of diagnosis of small cell lung cancer. A lot of patients will have a bulky chest mass. They might present with cough and shortness of breath. Many patients do have some degree of weight loss. There are also some things called paraneoplastic syndromes, which are brought about by hormones or molecules actually secreted by the small cell lung cancer. One of these is SIADH, so it's inappropriate release of antidiuretic hormone, which can cause hyponatremia, can lead to cramping, nausea, vomiting, and confusion. Lambert-Eaton syndrome is another paraneoplastic syndrome that can result in muscle weakness. So there are really a whole variety of different presenting symptoms for these. A lot of them are respiratory, but others are more systemic. For the staging of small cell lung cancer, I mentioned limited and extensive stage. And this is a little bit different from other cancers where you might think about stage 1, 2, 3, and 4. You can certainly give a numeric stage to small cell lung cancer, but what we think about really in a diagnosis of small cell lung cancer is the feasibility of a radiation field. So with a primary tumor and lymph nodes in the chest, we would think about feasibility of thoracic or lung radiation. Whereas if the cancer has spread, such as the picture on our right here, to the contralateral lung, to the brain, or to some other organ, this would be extensive stage disease, which I would not be able to encompass in a radiation portal. And at diagnosis, only 30% of patients are diagnosed with limited stage disease, and the vast majority have extensive stage disease that's spread beyond the lung. Staging can be a little bit controversial in this regard. What can truly fit in a radiation portal? The classic definitions would be one hemithorax with possibly the supraclavicular fossa on the same side. In the modern era, with modern radiation techniques, I could consider including the contralateral supraclavicular lymph node in a radiation portal, even though that was classically considered ipsilateral, or classically considered extensive stage disease, as well as contralateral hilar nodes were traditionally considered extensive stage. So with more modern techniques, larger radiation ports can be feasible. One thing within the chest, malignant pleural effusion would not be encompassed in a radiation field, and that would consist of extensive stage disease. The prognosis with small cell lung cancer can be related to many different factors. The stage of disease is, of course, a very important factor, but also age, performance status, weight loss, gender, and a variety of serum markers can be related to the prognosis of these patients. Small cell lung cancer is really thought to be a systemic disease, even when it's diagnosed in the limited stage. So this means that systemic therapy, such as chemotherapy, is really the mainstay of therapy. But obviously, I'm here speaking to you about radiation for small cell lung cancer. So radiation and even surgery can be important local treatments. And here I just have a diagram of an example of a radiation field for a fairly small volume small cell lung cancer. When we think of limited and extensive stage small cell lung cancer, for this limited stage disease, so which is confined to usually one lung and lymph nodes, we think about systemic therapy such as chemotherapy and local therapy. For extensive stage disease, the systemic therapy is truly the mainstay of treatment, and the local therapy might be considered on a case-by-case basis. And we'll go through several cases which would lend us to that. I'll focus first on limited stage small cell lung cancer. So first with stage 1 disease, which is a limited stage small cell lung cancer with negative lymph nodes. I'm not going to spend a lot of time talking about the management here, but here's a snapshot from the NCCN guidelines. This is a really rare occurrence to have a small cell lung cancer with no nodal involvement. In this case, we really want to make sure the mediastinal lymph nodes are negative for disease. And then these patients can proceed with surgery, such as a lobectomy, and then followed by systemic therapy. If the patient is not a surgical candidate, we could consider undergoing SABR or stereotactic body radiation, followed by systemic therapy. Or a course of conventional chemoradiation, which I'll talk a lot about for our node-positive patients. So there is a small but limited role for surgery in small cell lung cancer, but that's a little bit beyond the focus of my talk. This PET-CT here is really the picture more often of what I see for small cell lung cancer. And what this is an axial slice of a PET-CT. So we have the trachea here, we have this in the center, And you can see this uptake in a lot of mediastinal and hilar lymph nodes. So bilateral station 4 lymph nodes are involved here. A lot of bulky disease, whereas you don't see a large primary tumor. And this is what we're often seeing when our patients come through in our clinic. And so when I see these patients in our clinic, the treatment recommendation is going to be concurrent chemotherapy and radiation. The chemotherapy, which a little bit is beyond the scope of this, is typically cisplatin and etoposide. And then I will recommend radiation treatment, which is a series of X-ray treatments. But I want to take a step back here. What is radiation treatments? So radiation or high energy X-ray treatments focused on cancer, and it serves to kill the cancer cells by causing DNA damage, including double strand breaks. The cells are not burned. People think of radiation as often like burning things, causing skin burns, but these DNA strand breaks cause an eventual mitotic cell death. So that is how our radiation works. When I see a patient in my clinic for consultation, they are truly seeing me for a medical consultation and evaluation. Well, I'll see and evaluate the patient, and for our patient with limited stage small cell lung cancer, we'll think about performance status. We'll think about other medical comorbidities. We'll talk about if they're available to receive concurrent chemotherapy. We'll talk about their symptoms from cancer. And then after that point, we'll arrange a CT simulation if they're going to receive radiation in my clinic. And so here on our left is a picture of our CT scanner, where we'll do a scan to design our radiation field. After we work on our treatment plan, the patient will come in and receive their radiation treatments on a machine similar to the one that's on our right here. And this is one of our standard linear accelerators, where you can see the edge of the couch in the very bottom right of the screen. You can see some imagers on the sides. And then the treatment head is what delivers these high energy X-rays. So you can envision the patient lying on the table and receiving these X-ray treatments over the course of their therapy. The reasons that we do radiation, there can be a variety. We can do palliative radiation, which is more for extensive stage disease. But in limited stage small cell lung cancer, we are doing curative intent radiation without a surgery, which is definitive chemoradiation. In some situations, we might do adjuvant radiation, which is after a surgery. And rarely, but we do in small cell lung cancer, we talk about prophylactic radiation, which is radiation without visible disease. So for limited stage small cell lung cancer, our treatment is going to, again, consist of chemotherapy, which I mentioned, concurrently with thoracic radiotherapy, and potentially prophylactic cranial radiation, because this disease does have a tendency to spread to the brain. The patients will come through, have been staged with a PET CT, they will have been staged with a brain MRI, and then we'll talk about our treatment regimen. So for thoracic radiation, if these patients have undergone their simulation on that CT scanner, like I showed earlier, I will draw exactly where all the disease, the involved lymph nodes are, and create a radiation treatment plan, where these custom X-ray beams are performed in arcs around the patient, typically, to deliver the dose to the tumor. And if you think about the things that are nearby, this will relate directly with what some of the side effects of radiation. You can see sort of the green line actually cuts directly through the patient's esophagus in this situation. And you'll see esophagitis or irritation with swallowing noted multiple times in the side effects of thoracic radiation. And this is the reason why. So small cell lung cancer is pretty unique in that it's exquisitely radiosensitive. And so even low doses can kill a substantial proportion of the radiation cells. For this reason, we often use a low dose for each treatment for small cell lung cancer. And we can do twice a day radiation or BID radiation. And these multiple small fractions can be very effective at killing the small cell lung cancer cells, but they also have a radiobiologic benefit in sparing the normal tissues from late injury. And so this radiosensitivity was why in the past, the idea came up to do twice daily radiation for small cell lung cancer, whereas our typical treatments for other diseases might be just one treatment a day. In an old classic study by Teresi, they looked at conventional versus accelerated radiation for limited stage small cell lung cancer. The chemotherapy was cisplatin and etoposide, which is exactly what we would use today. And the radiation was either 45 gray and 25 treatments delivered once a day over 5 weeks, versus this accelerated fractionation, which is 45 gray and 30 fractions over 3 weeks. So it's a shorter course, but it's more intense with 2 treatments given each day at an interval of about 6 hours. And we can see here in terms of the outcomes of the study, the 5-year overall survival was 16% with daily radiation and 26%, so significantly improved with the BID radiation. There was also an increase in esophagitis, acute esophagitis, however, with 16% of the patients receiving daily radiation having acute esophagitis, and 32% of the BID patients. So at a risk of increased acute toxicities, we did have an improved survival benefit. And there was a lot of discussion after the publication of this paper, which was published back in 1999. And the argument was that these were not truly equivalent doses, that the 45 gray delivered in 30 fractions over 3 weeks was actually a much higher biologically equivalent dose. And therefore, it wasn't really necessarily a good comparison. But this paper really has been the mainstay of guiding our therapy for small cell lung cancer. Since that time, the thought was that we would look at higher doses. Perhaps a higher once daily regimen would be more beneficial in cancer control and improving outcomes. So there were a couple of studies looking at higher dose once daily regimen, again with concurrent cisplatin and etoposide, and comparing it to the Teresi BID regimen of 45 gray over 3 weeks. There was an experimental arm in the CALGB study, which was found to be less favorable than 70 gray in once daily treatments of 2 gray per fraction over 7 weeks. So these are the 2 arms that were compared in this study, the Teresi BID regimen and 70 gray and 2 gray per fraction over 7 weeks. The median overall survival in the study was 28.5 months in the BID arm and 30 months in the daily arm. The 5-year overall survival was, again, about 30% in each arm, which was not statistically significantly different. And then there was no difference in the grade 3 or 4 esophageal or thoracic toxicity in either arm. And so really here we could see with the higher dose once daily radiation, there really was not a difference in either acute toxicities or survival outcomes in these patients. The CONVERT study is another very similar study, again, a phase 3 study looking at limited stage small cell lung cancer patients, comparing the BID Teresi arm to 66 gray and 2 gray per fraction, so a little bit shorter course than the previous CALGB study. You can see here the numbers are quite similar, with median overall survival, again, in the 2.5 years, 30 to 25 months. With 56 versus 51% overall survival, so slightly higher in the BID arm, but not statistically significant, and similar 5-year overall survival as well. Which, if you can remember, that was 26% in the older Teresi paper, so maybe a little bit of improvement, but overall fairly similar over time. Again, there's no difference in esophageal or thoracic toxicity. And again, for the conclusion of the study is that there's no difference in survival outcome with the BID versus once daily arm. Because of the way this study was powered, it was powered to demonstrate superiority of the once daily arm and not a non-inferiority study. The conclusion of this study is that BID would still be considered the standard of care for these patients. So in the CONVERT study, mentioned the patients are receiving cisplatin and etoposide. The chemotherapy typically began with the second cycle of chemotherapy. And then in terms of the radiation treatment techniques, most of these were 3D conformal radiation. So 3D conformal radiation are static X-ray fields, which are custom shaped to the patient's anatomy and tumor anatomy. Some of them were the more modern intensity modified radiation, which is similar to the images where I showed before, where the radiation field is very customly shaped to the tumor. And importantly, there's no elective nodal radiation. The radiation fields truly only cover the involved lymph node and tumor areas in the patient's thorax. About 80 to 85% of the patients receive prophylactic cranial radiation, which is preventative brain radiation to prevent brain metastases, which I'll talk more about in some of the subsequent slides. So we showed these 2 studies now, looking again at once daily radiation and showing no difference with the BID radiation. There's another more recent phase 2 study that has been published looking at higher dose twice daily radiation. So this study compared again, the standard Teresi doses of 45 gray and 1.5 gray BID fractions versus 60 gray in the same fraction size. So a longer course of radiation, again, with the same concurrent chemotherapy. There was a statistically significant improvement in overall survival in the high-dose arm of this study, with a median of 37 months versus 22.6 months, and 2-year overall survival of 48% versus 74%. So actually fairly striking numbers here. However, what was interesting is there was not a difference at all in the median progression-free survival. So there wasn't an apparent difference in cancer control, but there was an overall survival benefit. So this is a very interesting study. It doesn't give us the answer yet, but it certainly showed that the higher dose twice daily radiation is worth pursuing in a phase 3 study. And so hopefully there'll be more to come on that. I did mention a little bit about the timing of radiation. So the patients are receiving 4 cycles of chemotherapy. And I mentioned in the CONVERT study, the patients started their chemotherapy, or started their radiation with cycle 2 of chemotherapy. This is an old study looking at early thoracic radiation. So that's radiation starting during the initial cycles of chemotherapy versus starting the thoracic radiation much later in chemotherapy when the tumor has had more time to respond. And also you could see the timing of prophylactic cranial radiation in this study. Interestingly, you could see that overall survival at 5 years was higher, statistically significant, than in the patients that received earlier thoracic radiation than in the patients that received late thoracic radiation. And so really the drive in these patients is to have the radiation delivered earlier in the course of therapy. And the thought that was that late radiation is really more becoming sequential chemotherapy and then radiation and not truly concurrent therapy. And this is just a combination of multiple studies, again, looking at the timing of the chemotherapy and the radiation. And they proposed an interval which is called the start of all treatment to the end of radiation. That's this SER. And said that, having this number within 30 days, less than 30 days, was associated with improved overall survival. And again, for these different studies, we can look at the day that radiation is started, 21 versus 105. And again, this is the study that had the 20 versus 11% overall survival. Again, starting day 1 versus day 42, we can see 5-year overall survival, 30 versus 15%. And kind of continuing down the line, you can see that starting radiation earlier is associated with the improved overall survival. And actually, each week of this increased in SER, the start of all treatment to the end of radiation, is associated with a 1.8% decrement in 5-year overall survival. So I think these are all really important factors that we think about when we're seeing our patients with small cell lung cancer, both the timing of the chemo and the radiation, as well as the radiation dose. So for my patients that I see in my clinic, I will recommend BID radiation to a dose of 45 gray because we do not have a phase 3 study suggesting that the benefits are the higher. It's only a phase 2 study. I typically begin my radiation with cycle 2 of chemotherapy. I would prefer cycle 1, but there's also logistics involved with that. Our patients can also often get a chemo chair within a couple of days of consultation with medical oncology, whereas I have to see that patient for the simulation and then create the radiation plan. So in terms of the timing, a lot of times it's more feasible to get them started on treatment quicker by doing the chemotherapy first and starting the radiation with cycle 2. But you saw the overall survival numbers with the once daily radiation. They were actually very similar, going to 66 or 70 gray in once daily radiation versus the 45 gray BID. So if I have a patient that due to social circumstances, financial circumstances, any other circumstance cannot manage the twice daily radiation, I have no hesitations with delivering once daily radiation because in all honesty, the survival outcomes are fairly similar. So now we will move on and, got a poll question here. What is prophylactic brain radiation? And I might have already answered this a couple of times during the talk so far, but prophylactic brain radiation, is it radiation to treat brain metastases, to minimize side effects of chemotherapy, to prevent the occurrence of brain metastases, or to palliate pain? All right, and it looks like most people are saying to prevent occurrence of brain metastases, we do have to treat as well as a little bit of pain palliation as our answers here. So prophylactic means the treatment delivered in the absence of known disease to prevent disease occurrence. So the incidence of brain metastases in patients with small cell lung cancer is actually 30 to 80% at 2 years. It is quite high. And this prophylactic brain radiation, which is typically 25 gray delivered in 10 once daily fractions, can be administered. There are some studies, which I'll delve into a little bit, that show this might improve survival. And it definitely does increase the incidence of brain metastases. But we know from studies of whole brain radiation, which is often given for brain metastases to a little bit higher dose of 30 gray and 10 fractions, this is associated with decline in memory, particularly delayed recall, such as the ability to remember a list of items. And we can also think that old studies didn't include an MRI for staging the brain. So let's think about the data for prophylactic cranial radiation in this context. And then here I've got an image of what actually a whole brain or prophylactic cranial radiation field. It's actually a lateral field from each side of the brain, custom shaped to the brain. You can see the brain contour in green, and the little bars are actually blocks. So you can see that the face is blocked from the radiation. So in this study, it's a meta-analysis of almost 1,000 patients from 7 trials looking at PCI, prophylactic cranial radiation, and limited stage small cell lung cancer. It actually showed an overall survival benefit in addition to a decrease in the incidence of brain metastases. So this is really a game changer. Any therapy that actually gives an overall survival benefit is really something that we want to be able to offer our patients. So that is why in some of the studies that I mentioned, every single patient received prophylactic cranial radiation because this is thought to be the best possible standard of care for our patients. However, when I talk about extensive stage small cell, I'm going to talk about some emerging data with the inclusion of MRI, and we'll talk a little bit more about what we should do for these patients, particularly with the context that it could have a decrement on memory and recall. So for limited stage small cell lung cancer, though, there are several new trials up and coming. NRG LU005 is looking at the addition of immunotherapy to concurrent chemoradiation, as is the Adriatic study. And there's also a study looking at PCI in the setting of MRI, so it randomizes patients with either extensive or limited stage small cell lung cancer to MRI surveillance versus PCI. So that's something I think in the modern era will really give us some answers about the benefit of PCI in these patients. I will now move on to extensive stage disease. So these are patients that that small cell lung cancer has spread either to the contralateral lung, to the brain, to the bone, to the liver, to the adrenal. Those are the most common sites, but really any other site of metastasis. So I would not be able to encompass all the disease in one radiation field. So radiation in this situation, just to revisit, would be palliative. It would be to help with a symptom, or potentially prophylactic, because patients with extensive stage small cell lung cancer have historically also received this prophylactic cranial irradiation. So what are the following are possible targets for treatment in extensive stage small cell lung cancer? So we have disease in the chest causing shortness of breath, brain metastases, painful bone metastases, or all of the above. All right, great. Thank you for your participation. It looks like the vast majority are here putting all of the above. And these are all certainly instances that I've delivered treatment for patients with extensive stage small cell lung cancer, whether it's disease compressing the airways in the chest, symptomatic brain metastases, or painful bony metastases. And you can see here, really, the target can be anywhere that the cancer is causing a symptom. It might be more rare, but we've had bowel obstructions from metastases from small cell lung cancer. Those can be treated with radiation. Painful supraclavicular adenopathy. There are really a whole variety of disease sites that we could consider on a case-by-case basis. But extensive stage lung cancer has, by definition, spread beyond a radiation portal. So the standard of care for extensive stage disease has historically been chemotherapy, and now with the addition of immunotherapy. Before the immunotherapy era, there was thought to be a benefit to consolidative thoracic radiation, which would be a radiation field after the delivery of 4 to 6 cycles of chemotherapy to the residual disease in the chest. And this showed an overall survival benefit of 13 versus 3% at 2 years. Caveats in this study, which I'll talk a little bit more about the design on the next slide, was that only benefited patients that did have some residual disease in the chest. It only it seemed better in patients that had less burden of distant metastatic disease. And it actually did not meet the primary endpoint. The study was designed to look at an improvement in 1-year overall survival. So the study is called the CREST study, Consolidative Thoracic Radiation in Extensive Stage Small Cell Lung Cancer, and randomized about 500 patients to thoracic radiation or not after completion of their chemotherapy. And again, looking at the Kaplan-Meier curve here, you can see their primary outcome at 12 months. There really was no difference in overall survival in these patients. However, the curves did separate some at 24 months or 2 years, but this was not the primary endpoint of the study. And then in terms of, on this forest plot here, you can see the biggest benefit or the lack of benefit would be in the patients that did have a complete response. Those patients really did not seem to have a benefit to the consolidative thoracic radiation. And the radiation delivered in this study was different than the BID radiation in limited stage disease. This was once daily treatment of 30 gray in 10 fractions. But chemotherapy alone is not the standard of care treatment now for extensive stage small cell lung cancer. There are 2 studies that have been published with the inclusion of immunotherapy. The first one, Empower 133, was a phase 3 adding atezolizumab in the first-line treatment for extensive stage small cell lung cancer. And in this study, it found an overall survival benefit of 12.3 versus 10.3 months with the addition of immunotherapy. A similar study, the Caspian study, was looking at the addition of durvalumab, so another immunotherapy agent to cisplatin and etoposide. And again, showing an overall survival benefit that is quite similar at 13 months versus 10 months with the control receiving only chemotherapy. There was no difference in toxicities in either of these 2 studies, but you can see with this statistically significant improvement in overall survival benefit, cisplatin and etoposide plus either durvalumab or atezolizumab. And sometimes carboplatin is also used for the platinum therapy, but these are the standard of care in immunotherapy. But an important caveat to these studies is they exclusively did not allow thoracic radiation. So in the immunotherapy era, we don't have any prospective data to decide to really help us decide on thoracic radiation. And there's a real potential toxicity risk. Radiation has a risk of pneumonitis, which is inflammation of the lung parenchyma. And this is also any pro-inflammatory side effect can be a side effect of immunotherapy. So we do think about a real combined risk here. So I think, consolidative thoracic radiotherapy is not something that we would consider using as the standard, but in patients with bulky residual symptomatic disease might be something, or if they have disease progression, that would certainly be an option for them. I'm going to talk a little bit more about prophylactic cranial radiation now. So there were also old studies showing an overall survival benefit in prophylactic cranial radiation in extensive stage small cell lung cancer. So these are patients with extensive stage small cell lung cancer, so cancer that has spread beyond the lung, who did not have evidence of brain metastases, showing an overall survival benefit at 1 year. However, more recently, we have a modern study which included MRI for staging. And what we worry is these older studies without an MRI, then perhaps we were treating smaller asymptomatic brain metastases, and that was what was causing us to see the overall survival benefit. So in a more modern study published in 2017, patients with extensive stage small cell lung cancer with good response to chemotherapy underwent an MRI at baseline, and patients with no brain metastases were randomized to PCI versus no PCI. And the patients who did not receive PCI received an MRI every 3 months for the first year, and then every 6 months after that. And this demonstrated that the prophylactic cranial radiation did increase the incidence of brain metastasis, so 69 versus 48%, but there was no difference in overall survival at 13.7 versus 11.7 months. And so this modern study is really what we think about, because this is more how we'll take care of our patients. And to be honest, many radiation oncologists are extrapolating this to our patients with limited stage disease and discussing it, although it does not quite apply. And this here is just an example of some of the survival curves here. So we've got overall survival, which there's no difference in the observation arm, which is in blue, and the prophylactic cranial radiation, which is in red. In the observation arm, there is a higher incidence in the lower left graph of development of brain metastases. And then overall progression-free survival in both patient arms, there is no difference with the addition of PCI instead of observation. So what about in patients that do develop brain metastases for extensive stage small cell lung cancer? Because we've mentioned how many of our patients are going to eventually, whether they have limited or extensive cell disease, eventually develop brain metastases. And brain metastases are not really a one-size-fits-all situation. Some patients might present with a large symptomatic metastatic lesion, could be a solitary lesion. Some people have just a few smaller lesions, or some patients might have widespread diffuse metastatic disease. The standard treatment for this patient population would have been whole brain radiation, which is exactly similar to prophylactic cranial radiation, but it's a slightly higher dose in 30 gray at 3 gray per fraction for 10 fractions. And this would treat all of the brain parenchyma, so we would cover any known disease plus any microscopic disease. In contrast, patients with a variety of other solid tumors who develop brain metastases are treated with stereotactic radiosurgery, which is small conformal focused radiation delivered in a single fraction to the isolated brain tumors. But in extensive stage small cell lung cancer or with brain metastases, does SRS really make sense in a population who would also be a candidate for prophylactic cranial radiation? The two, it seems like a little bit of a conflicting ideas for treatment. There's again some fairly recently published studies looking at a cohort of patients who did receive stereotactic radiosurgery for small cell lung cancer. It's a large group of 700 patients who had a median survival of about 8.5 months after radiation. The matched patients who received whole brain radiation were less likely to have distant CNS progression, which makes sense because any microscopic disease would have been treatment, but there was no difference in overall survival. The best outcomes are in patients with 5 or fewer brain metastases, which makes sense because often outcomes are correlated with burden of disease. But the reason this is really important is that we know from our other cohorts of SRS studies for which small cell lung cancer was a histology that was classically excluded, we know that patients that receive whole brain rather than SRS have definitely changes in memory following treatment, typically in the form of delayed recall, which in neurocognitive testing in clinic is noted by memorization of short lists and the ability to recall it at a time later. And so when talking with the patients, we discuss this as an analog as memorizing a short grocery list or coordinating your doctor's visits. And so it would be nice to be able to have rationale to deliver this stereotactic radiosurgery to patients with small cell lung cancer as well for this neurocognitive benefit. In some of the curves for the FIRE small cell lung cancer study, so this is looking at SRS, and you can see again, I mentioned the median overall survival was 8.5 months, which was not different from their matched controls who received whole brain radiation. This was not a randomized study. And you could see there was a decent incidence of CNS progression. The caveat is in these patients that do have distant CNS progression, just like in other disease sites, we can often deliver a second course of stereotactic radiosurgery quite safely with close surveillance. And then looking at the overall survival, as expected, you can see that the number of metastatic sites correlates with overall survival, with the best curve in gray at the top for one metastatic lesion. when you can see worse survival with greater than 11 lesions with a lower median and 12-month overall survival. And again, similarly, you can see that patients with one metastatic lesion might have a little bit less cumulative incidence of the development of subsequent brain metastases. So just a little bit better prognostically for the patients who truly have a single brain metastasis. There's one other brain radiation technique that I wanted to talk about for whole brain radiation, and that's hippocampal avoidance. So the hippocampus is this area that's delineated in red on these two brain MRIs, the sagittal and the coronal here. And the hippocampus is the area that contains neuronal stem cells that are thought to be able to replenish. And the thought was that if we can avoid these areas with whole brain radiation, that perhaps we could, maintain neurocognitive status. This has been well studied in whole brain radiation, but patients with brain metastases from small cell lung cancer were actually excluded from these studies. There is a recently studied randomized phase 3 study, and this is not looking at whole brain radiation for brain metastases. This is actually looking at prophylactic cranial radiation. So again, radiation in the absence of brain metastases, randomizing patients with small cell lung cancer to PCI versus hippocampal avoidance PCI. This was not exclusively patients with extensive stage disease, though I have this in our extensive stage section. Actually, 70% of the patients in these study had limited stage small cell lung cancer. So really all comers were eligible. And so these patients all were randomized to receive prophylactic cranial radiation. And you can see here the neurocognitive function was much higher after treatment in the patients who did receive the hippocampal avoidance treatment. However, there was no impact on quality of life. So the quality of life scales were no different in the patients receiving hippocampal avoidance PCI versus standard lateral field PCI. There was no difference in the incidence of brain metastasis. And that's important because a concern was that avoiding the hippocampal region, the patients might have a higher predisposition for development of brain metastases in this area that was spared from radiation. There also was not a difference in overall survival in this study. And so we now do have some randomized phase 3 data for using hippocampal avoidance in the setting of PCI, if that is something that a patient and the physician would like to deliver. Just some other examples. So this is not from a clinical trial, but I showed the radiation fields for brain radiation for small cell lung cancer. We also treat a lot of bone metastasis for small cell lung cancer. So these are just two examples of radiation fields. So this one, this patient in red, on the left in red, we have delineated some bone metastases, both in the sacrum as well as in the lumbar spine. And you can see this patient is treated with an AP and a PA field. It's weighted more posteriorly, but there's still a little bit of dose that goes through the entire patient's body. You can see the bladder is getting a little bit of dose. That's the structure in yellow. As well as some bowel anteriorly. But this is overall a very safe, typically a low-dose 20 gray radiation plan that can really palliate pain in patients with small cell lung cancer. Similarly, this is a patient with a metastasis to the femoral head. Again, this is on our right. Delineated in red would be the lesion. And you can see here from this view, we have, again, an AP and a PA field. We're looking at the coronal image here. And you can see the side effects might be a little bit different with this low dose because there actually is no bowel or bladder overlap for this. So maybe some joint fibrosis could be a long-term side effect. But overall, both of these would be pretty well-tolerated treatment to palliate pain in a patient with extensive stage small cell lung cancer. As we start to wrap things up, I also wanted to touch on the oligometastatic state, which is somewhat of a hot topic in thinking about local therapies for metastatic cancers. There's more and more emerging data in non-small cell lung cancer, for example, for treating of all metastatic sites of disease in patients with 4 or fewer metastases. You can also see similar paradigms for patients with a few liver metastases from colorectal cancer would be another example. So this has been looked at in extensive stage small cell lung cancer with patients with 4 or fewer sites of disease who were started on initial chemotherapy with a good response. They were randomized to prophylactic cranial radiation versus radiation to all sites versus prophylactic cranial radiation. The prophylactic cranial radiation dose was the standard 25 gray and 10 fractions, and other sites received a dose of 45 gray and 15 fractions if that was deemed to be safe. Some lower doses were allowed. This is actually a relatively high dose for small cell lung cancer. The outcomes in the study were much higher than historical controls, so patients lived, their survival was better than expected, but there wasn't a difference in overall survival. It was about 50% in both arms at 1 year. And there was a slightly higher grade 3 toxicity in the patients that received radiation to all sites of the disease. So based on this study, this is a small study which actually closed early. It did not completely accrue because it did not meet the pre-specified interim analysis criteria. But so we don't really have evidence for treatment of oligometastatic disease. So in extensive stage disease, most of our radiation is truly reserved for symptomatic or progressive sites of disease. So as we wrap things up, just to summarize here, we've talked about a lot of topics in radiation for small cell lung cancer. For limited stage disease, we talked about the definitive thoracic radiation, whether it's delivered BID or once daily. My personal preference is BID radiation. However, I showed you the data and survival outcomes in once daily radiation. As long as you're going to a dose of 66 to 70 gray, seems to have similar survival. A lot of patients or a lot of smaller clinics, the once daily radiation fractionation is just a lot more manageable. And this radiation would start with the first or the second cycle of chemotherapy, ideally. We talked about the role of PCI with an old study showing an overall survival benefit. The MRI surveillance study did not include patients with limited stage disease, but we do wonder that if with MRI surveillance, that truly would have taken away the survival advantage in these patients as well. And then for extensive stage small cell lung cancer, this is metastatic disease. The systemic therapy is the mainstay of therapy with our cisplatin or carboplatin and etoposide, and with a combination of immunotherapy. Radiation in these patients are often is reserved for palliation of symptomatic sites of disease. Prophylactic cranial radiation might be considered in some practices, and you could consider hippocampal avoidance in either set of patients that you're treating with PCI. And for brain metastases, SRS has become more and more acceptable. And in our clinical practice, that's what we're typically using, particularly in patients that have fewer than 5 brain metastases. I mentioned some of these upcoming trials. The NRG study as well as Adriatic, which are looking at adding immunotherapy to chemoradiation for limited stage small cell lung cancer, because right now the role of immunotherapy in these patients is uncertain. There is an NRG study looking at hippocampal avoidance PCI for small cell lung cancer, which has not been published, though I did show you the data from another phase 3 study on hippocampal avoidance prophylactic cranial radiation. NRGCC009 is looking at SRS versus hippocampal avoidance whole brain radiation for small cell lung cancer brain metastases. So again, adding tools to our arsenal. And an interesting study that I believe I mentioned previously is MAVERICK, looking at MRI surveillance versus PCI in patients with limited or extensive stage small cell lung cancer. And the PCI in that study can actually be standard lateral fields or hippocampal avoidance. So it's pretty broad inclusion criteria. And so what we need to think about for radiation is we are having advances in systemic therapy. We're adding immunotherapy to our patients. Now it's standard of care in extensive stage disease and potentially adding it to limited stage disease. And as we have further and further advances in radiation therapy, we really need to consider the advances in systemic therapy and make sure that these are going hand in hand and really improving treatment outcomes and not having too much of an increase in toxicity for these patients. And this is just one final slide with an example I have for you of radiation working for small cell lung cancer. This is a patient I saw a long time ago who presented to the emergency department, very, very short of breath. You can see on our left 2 slides. I don't think you can see my cursor, but you can see contrast in the blood vessels, and around the aorta and all the other blood vessels, you see a lot of soft tissue, a lot of mediastinal adenopathy. The trachea is substantially narrowed in this patient. A lot of times we will start with initial chemotherapy to shrink the disease in these patients because it can work quickly. But for this patient, we elected to proceed with thoracic radiation to quickly palliate her symptoms. The CT scan is, I promise this is the same patient on the right here, taken after about 5 or 7 fractions of radiation. And so this is a really tremendous response. The patient was able to be extubated shortly thereafter and went on to be discharged pretty quickly from the hospital with a really great response. And I believe we are accumulating some questions now. I think I'll turn it over to Andrew. But thank you so much for your time. I really appreciate it.
Yeah, thank you, Dr. Weiner. That was comprehensive and an excellent update in the research available. I want to remind everybody that the handout with all of this information is available on the course page. And we do have some questions coming in. While people are responding too, I learned a lot in this webinar, and for palliative care in particular, are there ever any side effects that would outweigh the benefits of any palliative care, or is it case by case?
That's a really great question. So our radiation doses for palliation of symptoms are intentionally selected to be low doses. We'll often do 5 treatment, a total dose of 20 gray and 5 fractions is a very standard dose. However, I think these patients can, if we're treating their chest, they can get esophagitis. That's often the week after they finish treatment where I'm not even seeing them, right? So I try to make sure I mention to the patients that this could happen. Another thing at that dose and fractionation, you can actually have skin changes. So I've seen patients in follow-up that they're like, I have this rectangle on my back. Why is there a dark rectangle on my skin? And so even at these low doses, you could have a long-term side effect of skin hyper or hypopigmentation. And so we think very carefully about side effect profile and try to counsel them. If I'm trying to palliate a thoracic disease, I am not going to treat to a dose of 60 gray and 2 gray per fractions the entire mediastinum because I know that is going to have a high incidence of esophagitis. And so that's not going to match with my goals. So we're intentionally trying to pick a dose that we think will be effective but not cause a lot of side effects.
Interesting. Thank you. And we do have one question that has come in as well. In the I'm going to mispronounce, Teresi study, was there a difference in duration of esophagitis between the short course and the long course of XRT?
Yeah, so Teresi looked at the 45 gray and 1.5 gray BID fractions over 3 weeks, and then 45 gray in 1.8 gray fractions over 5 weeks, and there was increased esophagitis in the BID arm. So yes, there was worse of a size. The duration, I cannot remember the answer. I don't know if that was actually described in the paper, but what's really interesting with the esophagitis in these patients. So when I am treating my patients in 3 weeks, their esophagitis starts really the last half week, the last few days of treatment, maybe the last weeks, and it's worse the week after. And so they're coming in for cycle 3 of chemotherapy, and that is when their esophagitis is at the worst. And usually I see them back about a month after they finished, and most are back to eating at their baseline at that point. For the once daily radiation, the time course of starting esophagitis is actually about the same. It's 2 to 3 weeks in, but then they still have a couple of more weeks to go. And the time course of resolutions tends to be about the same. But then you can remember in the once daily radiation to higher dose, the rates of esophagitis were about the same.
Okay. One more question. What triggers PCI?
That's a great question. So to be honest, in this situation, the patients that we will discuss PCI with are patients who have completed their initial therapy, whether it's extensive stage or limited stage disease, and have a response to therapy. In patients that haven't had a response to therapy, that's a really poor prognostic sign. They often need to move to a different type of systemic therapy, so we would not discuss PCI. So these are patients that have a response to therapy on scans shortly after finishing treatment. They're patients who have, again, another brain MRI that is negative for metastatic disease. And so those are 2 kind of criteria right there. And then I want to split up into limited and extensive stage disease. Most places where I have worked, PCI really has not been in the standard treatment for extensive stage disease. So I don't actually usually discuss it with those patients. I don't actually even necessarily see those patients because if remember, radiation has not been in their upfront treatment typically. So I don't think I've ever delivered PCI to a patient that has with extensive stage disease. In my patients with limited stage disease, I try to have as best as possible a balanced conversation. Now that's how much is a really balanced conversation remains to be determined. My preference is honestly MRI surveillance in these patients. I think that I truly value the better neurocognitive outcomes of avoiding brain radiation, but I have a subset of patients that come in and they tell me, I want to do anything that I can do to treat this cancer. And those patients I certainly have administered PCI to. The vast majority of patients, by the time they finish with the treatment, tell me they don't want to do anything extra. They are enjoying eating. They're enjoying not coming to see me twice a day for 3 weeks or once a day for 6 to 7 weeks. And we will do MRI surveillance. And I've been truly following the guidelines from that Japanese study for MRI surveillance with extensive stage disease with the MRI every 3 months for a year and then every 6 months. And that actually matches up and that's reflected in the NCCN guidelines.
Okay, very good. Well, let me just check real quick to see if there's one more question if you have time.
Sure.
Does PCI lead to brain necrosis and is there any way to prevent it?
So with PCI, I have never seen PCI or even really whole brain radiation lead to brain necrosis. Radiation necrosis is something more typically we would see in the patients who are receiving SRS. That can be even more common in the patients receiving immunotherapy. So the ways that we try to prevent radiation necrosis in the patients with SRS is there's certain dose constraints we think about. The dose constraint is the volume of brain receiving 12 gray or more in one radiation dose. And so we try to minimize that as much as possible in our radiation plans. But there's not really a metric for brain necrosis and PCI. That's a very good question. And I'm not going to say it never leads to it, right? Because we all know that things happen. But at that low overall dose, I really wouldn't expect that. And I wouldn't counsel that in my patients. Because even the quote unquote hotspot areas in the brain would not get more than above maybe 110% of the prescription dose of 25 gray. And that's still over 10 fractions. So it's very different than our single fraction doses.
Okay, good to know. Well, I think that's all the questions we have that came in at the moment. So thank you very much, Dr. Weiner. That was a wonderful presentation. Like I said, very comprehensive. And this information will be very useful for everybody to download again. Thank you. And I'm just going to go through a couple more things as we're filling up. I want to thank everybody on the UNC LCN team. We have Tim Poe, Veneranda Albure, John Powell, Oliver Marth, myself, Naja Brown, and Patrick Muscarella that work very hard to produce every one of these webinars.